Hello, everyone. My name is Roxanne Chabot from RBC Consultants. Thank you for joining our webinar. Today, we're going to be talking about skincare for cancer patients and survivors in the European Nordic region. As speaker, we have Dr. Ada Gurnita, who is a specialist dermatologist, head of the Skin Cancer Center in Karolinska University Hospital in Stockholm. We also have Dr. Samsa Kauppi, who is a private dermatologist in Terveystalo and Episalur in Finland. We'd like to thank our supporter, La Roche-Posay Laboratoire Dermatologique, for making this educational event possible. Before we begin, a couple of logistic tips for you. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your web browser following the webinar and will be emailed to you 1 to 2 days after the webinar. We'd greatly appreciate it if you could fill it in for us. Finally, within 1 to 2 days of the webinar, the recording of this program and a certificate of attendance will be sent to you via email. Again, if you would like to submit questions using the question chat pane to our faculty, it is on the right-hand side on your screen, and I wrote a little note there so you could see where you need to type in your questions. So without further ado, I am going to pass the floor virtually to Dr. Gurnita.
Thank you, Roxanne, for a very nice introduction. And thank you for La Roche-Posay for giving us the opportunity to present our paper and to make the whole process possible. Before we start, let's see, I have a question. And you can answer 1, 2, or all of them. Nice. I especially like the last answer, that more studies are needed to prove efficacy, because that was sort of our starting point for this paper. And the scope of a publication that I will go through today with my colleague Dr. Samsa Kauppi is to improve a cancer patients' and survivors' quality of life by offering guidance for preventing and managing cutaneous adverse effects. I will not go into all the methods that we use for publishing this paper. The paper was out in December in the Journal of Drugs of Dermatology. We went through the literature and we were thinking which one are describing best the current best practice in oncology treatment related with skin toxicity. So we selected the literature which was clinically relevant to our question. We were using inclusions criteria with guidelines, consensus papers. We were not so focused in reviews, but some of them are still used for the paper in order, since we were thinking that they are relevant. We use kind of a broad search terms with topical regimens for prevention, for treatment, for maintenance of radiation treatment associated cutaneous toxicities. We have health-related quality of life, skincare tools for choosing over-the-counter or non-prescription skincare. So we didn't got into the prescription part that much. We were looking at the adherence, the concordance, the efficacy, safety, tolerability, and of course, if they can cause skin irritation. The time span that we're looking for was from 2010 to 2020, that means 10 years. And to our surprise, there were not so much. We were using the normal, the known grading of clinical evidence. We were most searching for a grade A and 1, but that was not really easy to find. So basically, we found 106 publications, and only half of them could be included. In these 50, 18 was clinical studies, and 32 were reviews, 4 of them having guidelines and algorithms. When we were looking at the grading of these papers, as you may see in the column on the right, the best one were a B2 grading. So a lot of work is still needed to get, better quality and better studies on this topic. We were using a modified Delphi communication technique for interactive decision making for medical projects following the Agree2 instrument. And by discussing with a panel of experts, we have the help of 2 colleagues from Canada as well, which were more used with the system and were helping us a lot with it. We end up with 5 statements, which are shown on the screen. I will go through the first 2, and my colleague will go through the last 3 ones today. So if we go to the first statement, that dermatological toxicity associated with cancer treatment are common and can significantly impact the quality of life and disrupt cancer treatment. So what can we say about this statement? Well, we have a problem with cancer. The cancer is increasing. Here it's marked for the Scandinavia in dark blue, but you have a statistic for most of the countries around the world. If we look at what type of cancer we see in the Nordic countries, we have the lung, the breast, the prostate, and the colorectal, which are very common. And it's estimated that these 4 types of cancer will account for almost half of all cancer diagnoses in the Nordic countries. And then, of course, we have a skin cancer, which is defined differently. Normally in the statistic, we have skin cancer by the squamous cell carcinoma, and then we have a separate statistic for melanoma and the basal cell cancer. If we're looking at the basal cell cancer, for instance, the number is higher than both breast and prostata cancer together. But of course, you can always say that, well, you don't die in basal cell cancer. On the other hand, you might have like really bad adverse effects of a treatment. In the Nordic European countries in 2010, the relative survival percentage in Sweden was 70 and 69 males and females. So we are over the half, but still we see an increase both in diagnosis, in treatments, and a lower mortality rate, which means that we have more people which are living with or surviving from cancer. And now I'm talking like general cancer, not only skin cancer or breast cancer or prostata. And that also means that more people will have skin changes or sequels after the anti-cancer treatments, which will be shown on the skin. So the cutaneous adverse effects will affect the quality of life of a patient, the treatment adherence, the psychological well-being, and of course they will indicate in some cases a therapeutical response. If we're talking about the quality of life, the patient most frequently report that the skin adverse effects will really carry a negative impact, and they're unanticipated prior to therapy. Of course, they get the information that you might get a skin rash, but when they end up there, first, it's not certain that they will correlate it with a treatment, or second, if it's really bad, they will kind of like, oh my God, this is much worse than I was expecting. And we have, to deal with that as medical doctors. But treatment adherence. A lot of patients will decline to get the cancer treatment because of fear of hair loss. It's a lot of dramatical changes, like psychological changes in women at most, when they hear, okay, I will lose my hair. Am I prepared to face that? Because I have my friends, my family all around me. Maybe I don't want that everybody will know that I'm undergoing a cancer treatment. And I think that 8%, it's a very high number to decline a treatment for something that might eventually kill you. Psychological well-being. The skin changes induced by radiotherapy, for instance, will negatively impact the physical well-being, the body image. It leaves scar. Scar resulting from oncological surgical procedure can lead to psychological problems in 15% of survivors of childhood cancers. But I mean, when we are looking at anti-cancer treatments, we have the old one, we have the radiation, the chemotherapy, we have the new ones, the targeted therapy, the immunotherapy. We have the hormonal therapy, we have the surgery, we have a transplant. All of them are potentially giving skin side effects. When we're appreciating the amount of side effects that they get, we usually use the 5 grades, and I will not go into details for 1, 2, 3, 4, and 5. But when you end up on the grade 3 and 4, it will be a balance. Okay, we have a potential cancer treatment that works, but we have so much adverse effects that the balance will not be as clear cut. Should we discontinue the cancer treatment? Should we lower the cancer treatment dosage to not life-threatening the patient on other sides, like the skin? Radiation has the target, it's like a non-specific DNA damage. And you might have like acute or chronic side effects. Of course, if they're acute and mild, like dry desquamation and moderate erythema, that's something that easy can be handled. Moist desquamation, bleeding, pain, and ulceration would be a little bit harder. Can we do something to prevent to get to the severe one? And it's not just radiation for breast cancer, for instance, but you might think, okay, we do use like mild radiation, like gray rents for treatment lentigo maligna on the face. It might get the acute severe pain and ulceration as well. The chronic damage will lead to pigmentary alteration, to telangiectasia, to atrophy, to fragility, alopecia. Usually it comes back after chemo, but after radiation, it might be permanent. You might get sweet gland atrophy and necrosis. And not on the last road, a skin cancer as well. Here you have the pictures from grade 1, like really discrete erythema, all the way to really desquamation and ulceration and bleeding from minor trauma. So the skin is really, really taking a lot of damage. You have a chronic radiation damage, hyperpigmentation, you have a discoloration. Of course, you can do something, to cover it, but the patient will be disturbed by it. You have a telangiectasia, especially if you have a woman and get, the radiation on the breast, it will leave this mark. Will be very difficult afterward. She will get the questions all the time, like, what have you done here? The chemotherapy, it's supposed to disrupt a specific phase of cell cycle in actively dividing cancer cells. You have a non-specific effect and you have a specific effect. Alopecia is the one which is mostly known. It comes back, the hair comes back after the treatment, which is good. Sometimes, however, it will have another texture, and that's something that you have to inform the patients of. You might have chemotherapy-induced acral erythema. Some of the dermatologists will think, okay, this is a clinical picture of a dermatomyositis. Of course, you need to take all the blood samples and to take a biopsy to confirm it. But the chemotherapy can give this type of skin effect. This one was like 2 weeks after the start of paclitaxel. You might have changes in the nails. Think about the patient that work with the hands that will serve something that's going to be a problem. You might have an intertriginous reaction. Here is with a combination of busulfan and fludarabine. It's a conditioning prior to peripheric blood stem cell transplant. Again, intertriginous reaction to doxorubicin. The new treatment, are they better? Of course, they are better in order to treat the cancer. But how about the side effects of the skin? The targeted therapy, a lot of molecules. Here are just a couple of them. Lots of them are under development, and all of them give more or less skin side effects. Here's the vemurafenib-induced BRCA-ABL or BRAF morbilliform eruptions. Here is the hand-foot skin reaction, different grades of it. Of course, the patient will complain that they cannot use their hands. It's painful, they cannot walk. This one is a patient that had melanoma with metastasis, was set in on vemurafenib since he was BRAF positive. After a couple of weeks, he couldn't use either the hands and the foot, and we had to change the treatment with complete recovery of the skin. The AGFR or MEC will have papulopustular eruptions. The patients will complain, well, I look like my teenager girl. It's not okay. Can you do something about it? Immunotherapy, it activates a host immune mechanism. It's well known that a part of the immune system is very strong in the skin. That's one of the reasons that you can get like a transplant of heart or kidneys or liver, but you can't really get a fully functional transplant of skin from somebody else. You have the unspecific rash, and as on the other situation, you might have alopecia, you might have vitiligo and blisters, and not to forget the most advanced when you lose basically all your skin like a tan. So anti-cancer drugs and radiotherapy alters both the function, the anti-radical function, and the innate immunity in the skin. And of course, misery loves company. So you will never get the patient that has only one side effect. They will get plenty of them. The second statement that I will briefly talk about is that early education and appropriate skincare, including cleansing, hydration, and photoprotection, may improve quality of life and prevent severe skin side effects for cancer patients and survivors. Although data is scarce to support the prevention of severe skin sequelae for cancer patients and survivors, we agree that early education is beneficial for patient. And I will think about one of my patients who was on a BRAF inhibitor. She was informed that her skin will get more sensitive to the sun. She went out for a walk with the child, and then she washed her hand for some reason, and she forgot to put the sunscreen again, and she got the burn on the back of her hands. So information. You need to have a multidisciplinary oncology team, including dermatologists, to build all the treatment, to explain for the patient, this is the cancer treatment, these are your side effects on different levels, of course, on different organs, and how to take care of the skin so that you delay or you lower the amount of side effects that you can get. You need to give a patient an information, preferably a written information, so that they know what to look for. And it's worth remember that sometimes the skin changes can reflect internal organ damage, like the liver damage or vasculitis. There are a lot of resources on the net that one can print or send the link to the patient. And of course, it's important to explain for the patient that it's not up to them to decide if a skin event is a reaction to the treatment or not, but all the skin events that happens have to be reported. And then they have to know to whom. Is it the contact nurse? Is it the doctor? Is the oncologist? Is the dermatologist? You have to have a plan to present it to the patient. So everything that happens, they know what to do. Of course, giving them a glossary with pictures always help. And now my colleague Sam Sakopi will take over and go in more details. What can we do more to minimize the skin side effects?
Dr. Kaupi, we can't hear or see you. If you could click on your microphone and your camera. There we go. Oh, we can't hear you. There we go. You got it.
Okay, now I'm not unmuted. Okay. Thank you, Ada. I will continue. So let's see.
Oh, polling question.
Yes. So, do you recommend the use of skincare products for your cancer patients? And you can select one of the following. Yes, I recommend the use of skincare products for my cancer patients. Yes, but I'm unsure that if they actually use them. No, I delegate the recommendation of skincare products to other people, nurses or other assistants. I do not recommend the use of skincare products, or I don't know which products to recommend to my patients. I know that it's easy to choose more than one. Okay, we have some difference here. Okay, so I know that there's people that don't know what to recommend. I will try to help you with that. And I know the problem with skincare is always the adherence to the care. You should like sell to the patients why they should use the skin cream, what is the reason that they should use, and make it the easiest possible. So it's very important to like, you have to be a salesman for these skincare products. Otherwise people don't use it, especially men. and I would say like men like from 40 onwards, they are really difficult to get use a lot of skincare products. So the statement we made is that effective skincare for cutaneous toxicities should be based on evidence. It should be safe, it should be effective and non-sensitizing, and have a pH close to that of the skin surface. Okay, let's see.
There you go.
Line. So for the skincare for cutaneous adverse effects, preventive measures for cutaneous adverse effects, including skincare regimen, should be used throughout cancer treatment and continued after that. The skincare regimen comprises of gentle cleansers, moisturizers that help restore the skin barrier integrity and function, and also photoprotection using avoidance measures and sunscreen. Products that contain allergens and irritants should, such as common preservatives causing allergy, fragrances and perfumes, are unsuitable for oncology patients. And soaps and surfactants and detergents, especially those with an alkaline pH, remove skin lipids and elevate skin surface pH, triggering inflammation and lowering the diversity of skin microbiome, and also should be avoided. This is a very important thing. Always say to the patients, don't use soap, use moisturizer instead of soap, or use like a special cleansing cream. So for the use of moisturizers, the moisturizers form a barrier that helps prevent the transepidermal water loss. Always when the keratinocytes are not so adherent with them, or the skin is a little bit thinner, so then we have more water evaporating from the skin. And hydrophilic humectants such as glycerol, globulin glycol, butylene glycol, and those fruit acids like alpha hydroxy acid, like lactic, glycolic, and tartaric acid, may help to retain the moisture in the skin. And those fruit acids should be used with caution, as they can change the skin surface pH and be irritants. It's better to use more ordinary creams that contain glycerol or propylene glycol or stuff like that. Also, dexpanthenol supports stratum corneum hydration. It reduces transepidermal water loss and maintains skin softness and elasticity. Maybe the biggest brand here is bepanthen with dexpanthenol. The growing body of evidence on skincare regimen for the prevention and treatment of cutaneous adverse effects shows benefits for cancer patients undergoing anti-cancer treatment and cancer survivors. However, the evidence on specific ingredients is scarce. Okay, here I will present you a study concerning radiotherapy for breast cancer. This study had people use protective skincare products in the daily prevention and treatment of cutaneous toxicity for radiotherapy of breast cancer. And in this study, let's see when the slide changes. There's some lag. Okay, it was a multi-center prospective study of 253 women with breast cancer, evaluated the tolerability and the benefit of skincare for preventing the cutaneous adverse effects. These are the products here on the right. You can see the products used. They included thermal water containing products, a cleanser, emollient, healing cream, and sunscreen. The skincare regimen was used during the 6 weeks of radiation treatment, and it demonstrated fewer cutaneous adverse effects for those that use skincare every day compared to patients that applied less skincare. So the patients were divided with the low users and heavy users. Heavy users used the products every day. The low users used it from time to time, or some a little bit more often. Let's see the next results. So here you can see the results. So for the low users, 86% got patients benefited the treatment, and for the heavy users, 93% benefited from the treatments. Here are the things studied on the right. So it was very beneficial for radiotherapy treatment as when you are receiving radiotherapy treatment, you should use these products. Again, there's a huge lag. Okay, so nearly 2/3 of all cancer patients in the US will undergo radiation therapy, and more than 90% of those patients experience radiation dermatitis. Historically, patients have been advised to avoid skin creams in the hours before radiation treatment. It was thought that the skin cream would increase the radiation absorbed by the skin. However, recent findings show topical skin applications do not increase radiation dose in the skin and can be used in moderation before daily radiation therapy. It was shown in the study by Baumann. I will show you a little bit more about that. So, no difference in the radiation skin dose with or without the skin creams was seen, while surface radiation dose increased with a very thick layer of cream. No increase was found in the surface dose with a moderately thick layer of cream. And still, it's common practice for physicians and nurses to advise patients to avoid applying skin products prior to radiotherapy. 91% of responders regularly tell patients to avoid skin cream, and 83% of patients said they received this advice. And these results debunk the myth that skin cream use increases the amount of radiation the skin receives, causes more damages to skin unless an extremely thick layer of cream is used. So normal amount of skin cream before radiotherapy is okay. Only an extremely thick layer of cream can increase more damage to the skin. Okay, here is the skincare regimen we in our study recommend. So for the hygiene, instead of soap, people should use gentle cleanser daily. For the skincare, people should use moisturizer cream or skin repairing balm. Here are the products down. You can see, for example, Lipicar or CeraVe or something like that. For the hand and foot skin reaction, people should wear comfortable socks and shoes or try gel insoles. They should protect their hands and feet against injury and should not put too much weight on their hands and feet, especially during the first 2 months of treatment. The creams that should be used should contain urea or salicylic acid. Urea is the same as carbamide. In the Nordic region, for example, Canoderm is a 5% urea cream, can be used. Also, the Finnish preparations, Karbalan Plus are urea creams. Salicylic acid is there's so many products over the counter with salicylic acid. Also, people should gently remove the excess calluses. It's better to use a curettage, like a circular knife, than to use like a file. If you rub with the file, it can cause more calluses to appear. And after removing the calluses, people should apply skin repairing balm or urea-based cream once or twice a day. And if there's fissures, they are sometimes associated with calluses. So first remove the calluses, then apply a skin repairing balm or urea-based cream once or twice a day. If you can afford it, you can use a hydrocolloid dressing such as Tegaderm or like Duoderm. There's many products. They are quite expensive, but still you can use it for many days. It has a glue that it glues on the skin, so it forms a layer that protects your skin, and so it's not so painful to walk or do anything. But sometimes on the legs, those hydrocolloid dressings tend to rub away when you try to walk, so for many people, the use of super glue like ethyl cyanoacrylate glue you can find in like a normal convenience store. There's also like acrylate glues that are used for the medical procedures, but it's usually a little bit different. It's N-butyl cyanoacrylate more, but it's not that as much causing contact allergy, but otherwise you can still use the normal super glues for this. So for the fissures, you can when you put on the super glue, it comes as a liquid, and very fast it forms like a thick hard layer that protects your skin. Adhesive tapes could also be used to protect the underlying tissues. Photo protection is important. It can be done using protective clothing. It can be done also with the sunscreens. You should use at least a sunscreen with sun protection factor over 30, and you should use it every 2 hours when the sun is shining, especially during the midday from 11 a.m. to 3 p.m. Okay. I don't know if I have control or there's a huge lag. Okay, good. So there's also xerosis, and meaning the drying of the skin, and pruritus, meaning the itching of the skin. So this is very common with cancer treatments. The basic treatment protocol is, again, so that people should not use the soap. They should use a gentle cleansing product. They can use a moisturizer instead of soap, or bath oil instead of soap. And they should use a non-occlusive moisturizer and use photo protection. And if there's pruritus or erythema, so itching and redness, so then people should start using topical corticosteroid. You can use mild corticosteroids which you can get over the counter, or you can prescribe class 2, class 3 corticosteroids. Those need a prescription. Systemic treatment, you can use antihistamines. You can use 2 to 4 tablets a day. They are not very effective. Usually cortisone creams are more effective than the antihistamines, but the antihistamines are very safe. Okay. So for the cracks, when you have cracks, the basic treatment protocol is the same. So avoid using soaps and use a moisturizer or skin repairing balm. But if you have a severe cracks that cause pain, you can use a hydrocolloid dressing like Duoderm, or you can use the super glue or other like skin glues. The cold cream and vaselines are a little bit better when there's cracks, but otherwise the products are basically the same. And for the hand, foot, skin reaction, again the same basic treatment protocol. And if you have itching or the skin gets very irritated, then you should start using betamethasone ointment. Ointments are better than creams, and betamethasone is a class 3 corticosteroids. It should be used in the evening. Usually you use 1 fingertip unit, meaning that you use like you make like a worm out of the bottle to the first like first joint on your hand. So that's the right amount, and use it every day. Usually ointments for the feet are better applied in the evening when you have more time and you can go straight to bed. You can also, if there's hydrokeratosis, you can use 30% salicylate vaseline. This can be at least in Finland, we have to prescribe it for the compounding pharmacy so that the patient will get it, but maybe in some other countries it's more readily available. And for the EGF rash, like the acne-like rash, here it's been named folliculitis. The most important thing is to start the perioral antibiotic treatment. It's better to start it preventively before the symptoms start. So when you start the EGFR oncology treatment, you at the same time start using doxycycline, limacycline, or minocycline. And if there's pruritus and pain and local reaction, still you will start using class 2 corticosteroids. You have to prescribe them, and you can go up in the class of corticosteroid if the skin reaction gets more severe and causes more psychological impact. Still, the basic treatment is again the same, so that you avoid using soap and you use moisturizers and photoprotection. A very important thing is also the corrective makeup, so that because when they are red, they are more visible, those folliculitis bubbles, and especially almost always when the reaction heals, it leaves marks, it leaves the redness and the post-inflammatory hyperpigmentation, and that can last for a long time. And if the patients start using corrective makeup, it will be much easier for the patients to tolerate the redness and the hyperpigmentation in the skin. It's very important that you advise, especially the men, also this corrective makeup. I always do it, and I find it that when I like sell it to my patients, so they are using it, and I also sell it to my acne and rosacea patients so that they will use. Of course, I don't sell it myself. I mean that I try to try them to see the benefit in using makeup, why you should use makeup, and how it's easiest to be used makeup. Okay, and if there's these EGF rash reactions, sometimes very rarely, especially if you use the preventive antibiotics, can cause a secondary infection that is more severe, then you should take bacterial and viral sampling and use the antibiotics or viral medication according to the sampling result. Also, the prevention of UV is essential for EGFR rash. Okay, for maculopapular adverse events, if there's presence of itching, you should use antihistamines. Otherwise, you just use the same skin care regimen, so that avoid using soap and use moisturizers, preferably non-occlusive moisturizers. Our fourth statement is that effective management of dermatologic toxicities associated with cancer treatments is a multidisciplinary effort involving dermatologists, oncologists, primary care physicians, and other healthcare professionals involved in cancer treatment. Telemedicine may be of benefit in this area. an interdisciplinary professional oncology team approach from the start of anti-cancer treatment is the most efficient way of providing cancer patients and survivors with cutaneous adverse events the required dermatological care. Chemotherapeutic agents frequently cause cutaneous adverse effects, yet up to 84% of cancer survivors with these adverse effects are not referred to a dermatologist. Medical oncologists are more likely to pause or discontinue anti-cancer treatment due to cutaneous adverse effects, contrary to dermatologists who may prevent avoidable treatment interruptions. Also, the interdisciplinary oncology team approach may help identify and assist in managing dangerous or life-threatening cutaneous adverse effects. Early and effective use of skincare regimen may improve quality of life and may be able to preserve anti-cancer treatment. However, the adherence to the skincare regimen is not for sure. You have to always recommend the patient to use and tell them why they should use the skincare regimen. So, oncodermatologist, skin toxicity teams provide urgent access. They manage dangerous or life-threatening toxicity, symptom and quality of life management. They preserve anti-cancer therapy whenever possible. They classify the eruption, and they collect potential prognostic or mechanistic information. Why is it crucial to manage cutaneous adverse events induced by cancer therapy? They are visible. They alter the self-images of patients. There are many cutaneous adverse effects that concern the parts of your skin that are always in use when you communicate with other people. For example, the face, people always see the face, people always see the hands, and always when you can see the adverse effects, it's worse than if it's hidden. Visible cutaneous adverse effects reveal what he or she wants to keep a secret, the cancer. And they affect quality of life and impede interpersonal and emotional life. Some people don't want to be seen with other people when they have these skin problems. They might just stay at home. Treating these cutaneous adverse effects can increase the adherence and thus the success of anti-cancer therapy. So you don't have to stop the anti-cancer treatment so easily when you use these protocols. Why involve dermatologists? We are experts in skin and skin disease. Oncology patients are no different. The skin doctors improve patients' quality of life. That's what we do. We don't save lives. We improve the quality of life of our patients, hopefully. We improve the treatment outcomes through the adherence so that you don't have to stop the medication so easily. And we rule out the life-threatening conditions. And also, we use systemic steroids early and liberally if life-threatening. So the challenges for dermatologists: participation in the success of the treatment by preventing the patient to stop too early the treatment due to cutaneous adverse effects, preventing the development of cutaneous adverse effects induced by anti-cancer drugs is now a high challenge with the arrival of adjuvant setting. Treating these adverse effects induces by anti-cancer drugs improve the quality of life of patients and has a psychological impact. Educating the patients about the interest of skincare as a lack of knowledge for this population has been identified. If you don't tell the patient to use the skincare products, they won't use it. That's the life of dermatologists. Telemedicine and medication, we recommend education, optimal communication, access to support information, and early reporting of cutaneous adverse effects with the use of dermatologic services. There's a lack of dermatologists, so we should use telemedicine. For example, I myself had urgent hotline phone so that the oncologist or oncology nurses could call me always, and I will give them information how to treat the skin and the adverse effects. But in my case, I had it for like 2 years. There were maybe about 20 consultations during that time, so I had to always walk with the phone. So we stopped the try like a few years ago. But I still, if you have questions in Finland especially, I can maybe help you if I just have the time. Teledermatology is very easy, and virtual consultations are now very easy to use. Also, people are used to using it, so it's not such a big deal as it used to be. For example, I also work in the hospital in the southeastern Finland. I do like 50% of my work is teledermatology, and I also have a firm that does teledermatology for at least 30 cities in Finland. So we do a lot of telemedicine, and it's very easy to use, and it's very good to have dermatologists available to teledermatology. Okay. So the final statement is that camouflage can mitigate some of the stigmas of cancer and contribute to a better quality of life. The studies, a systematic literature review that included 18 studies, reported reduced quality of life impact when using cosmetic camouflage in patients with skin disfigurement. There was a randomized controlled trial of 66 female head and neck cancer survivors. It reported a 3-month skin camouflage program effectively improved facial disfigurement, fear of social interaction, and anxiety of social interaction and body image. There's also you don't need very big things. If you only use camouflage makeup, you usually use the type of makeup that is the same color as your skin, and there's special techniques in skin camouflaging. There's the second skin technique, and there are sometimes these patients would benefit like a personalized teaching of skin camouflaging, but that's not always possible, and there's many good camouflage makeup brands that can be used. You just have to learn one in your area. For example, in Finland, I have advised the using of Vichy Derma blend because it's very available, but I'm sure that La Roche-Posay also has very good camouflage products. Okay. So the conclusions: cancer treatment-related cutaneous adverse effects are very common and can severely impact patients' quality of life and interfere with the cancer treatment outcomes. The NECOM project explored clinical insights in cutaneous adverse effects and focused on skincare regimens involving hygiene, moisturization, sun protection, and camouflage products. The evidence and opinion-based best practice recommendations for oncology skincare programs aim to support all Nordic European healthcare setting stakeholders working with oncology patients. When applying the skincare regimen throughout the entire continuum of cancer care, optimal outcomes can be achieved, improving patients' quality of life.
Wonderful. Thank you so much again to La Roche-Posay Laboratoire Dermatologique that made this webinar and educational event possible. Again, if you would like to ask any questions, just use the question chat pane on the right-hand side of your screen. And also, if you have any questions that you think of after this webinar, you can also send it to info@rbcconsultants.com. So we have time for a couple of questions. So if you could come back onto the screen, Dr. Granita, and we will look at the questions that have just come in. So one of the questions is, have you had to stop cancer treatment in the past due to cutaneous adverse events?
Do I answer, or Ada?
You can
Or both.
both.
Yeah, I can answer first. So I never take away the cancer medications. That is the job of oncologist. But I will make recommendations if a patient is referred to me, and usually my recommendation is that do not stop the cancer treatment. Just start on the skincare regimens, and things will be fine. Of course, there are cases where the cancer treatment should be stopped for a while, but then it should be continued again, maybe with the same dose first, or with the second, if the adverse effect comes again, then with a reduced dose. But I only give recommendations, and the oncologist have to make the decision of ceasing the medication.
We have a lot of patients with melanoma and a lot of patients with lung cancer that are going on anti-cancer treatment with targeted therapy. They do get a lot of side effects on the skin. And usually we discuss this patient at the multidisciplinary conference where we have the oncologist and the dermatologist. As a rule, we try to treat the adverse effects on the skin before we change the oncological treatment. Most often the oncologist will lower the dose for a while to see if we can get a good balance between the side effects and the effects of the treatment, of a cancer treatment. If that's not good enough, then they might consider stopping the treatment or changing to a different product or adding a new treatment which is known to lower the side effects on the skin. So yes, it happens that we help the oncologist in adjusting the oncological treatment.
Thank you. Another question, do you find cutaneous adverse events difficult to treat?
The short answer, yes. I mean, it depends, of course, on the grade of side effects. If they are mild, they are usually easier to treat. If they are more intensive, they are, of course, not that easy to treat. It depends, of course, when the patient is referred to us. If it's early in the development, we can do a good treatment. But if they come late to us, of course, it's going to be a lot more difficult.
Yeah, I think for many dermatologists, there's a lot of cancer medications. As always, new ones comes to the market, and it's very hard to keep in touch with the newest cancer medications. I'm, for example, a little bit more involved in this issue, so I know a little bit better. But many times the issue is also, is the skin reaction due to the cancer therapy, or is it just another rash, or like people are stressed when they have cancer treatment? They can have like worsening of atopic eczema, psoriasis. They can have like lichen planus or stuff like that. So it's not always the cancer treatment that's causing the problems, but so that's sometimes an issue also. They are a little bit harder to treat, I have to say, than my normal patients. Yeah.
Well, unfortunately, this is all the time we have. Thank you so much, Dr. Kauppi, and also Gernita, for very thorough and important presentations for skincare cancer patients and survivors all over the world, but also sharing your experience and your pearls with your patients in the Nordic countries. And thank you all for joining us today. Goodbye, everybody.
Bye.